Congenital dyserythropoietic anemia type 2. It's an autosomal recessive disorder. Genome-wide linkage analysis identified an area of chromosome 20p11.2 as the location of candidate CDA-N2 gene that was later identified to be SEC23B gene. So this gene is known to encode the cytoplasmic coat protein 2 component SEC23B that is involved in endoplasmic reticulum vesicle trafficking. So these gene mutations have been associated with majority of cases involving CDA2. There are more than 450 reported cases, making it the most common form of congenital dyserythropoietic anemia. In contrast to type 1, diagnosis is usually made later on in life, often because symptoms may be milder, but also because it may be misdiagnosed as hereditary spherocytosis. The characteristic findings include anemia, jaundice, hepatomegaly, and splenomegaly, the same as we found in type 1. There is also symptoms of iron overload. The anemia here is normocytic and generally milder, with few or low reticulocytosis, unlike in type 1, where the anemia is macrocytic. Hemoglobin levels are lower in children than in adults and ranges between 8 grams per deciliter and 11 grams per deciliter. Anisopoikilocytosis is also present here, just like it was in the type 1, and this is variance in the red blood cells, the size, that is anisocytosis, and the shape, poikilocytosis. Combination of both of them is referred to as anisopoikilocytosis. Occasional basophilic stippling as well as binucleate erythroblast may be seen on a peripheral smear. The bone marrow aspirate is normoblastic but hypercellular with erythroid hyperplasia. Pseudogaucher cells may be present. Electron micrographs show vesicles laden with endoplasmic reticulum proteins running beneath the plasma membrane. CDA2 is also known with the acronym HEMPAS, HEMPAS, that is hereditary erythroblastic multinuclearity with a positive acidified serum test. This is because it features both erythroblast multinuclearity and circulating RBCs that are sensitive to lysis by acidified normal serum. Around 10% will require red cell transfusion in infancy and childhood, but rarely in adulthood. Unlike CDA type 1, splenectomy here may offer some hematologic improvement. Splenectomy does not prevent further iron overloading, mostly because of the persistent ineffective erythropoiesis by the bone marrow. Just like with the CDA type 1, secondary hemochromatosis is the most common long-term complication as well. Most patients can lead a normal life with a normal life expectancy, especially when complications are managed appropriately. Thank you.